Hello, I am Dr. David Maidment, a lecturer in psychology within the School of Sport, Exercise and Health Sciences at Loughborough University.
Hi, I'm Maria Goodwin. I'm a PhD student at Loughborough University, supervised by Dr. David Maidment and Professor Hogervorst. And today we're going to be presenting work I've been completing during my PhD, looking at the associations between hearing loss, non-communicable diseases, and physical activity.
So in terms of a summary of the material that we're going to be covering today, I'm going to be presenting a very quick overview of existing research in this area, assessing associations between hearing loss and non-communicable disease, as well as hearing loss and physical activity. Maria then will be discussing two observational studies that she's completed, assessing associations between hearing loss, non-communicable diseases, and physical activity. And then I'm going to be presenting some of the findings from a systematic review that we've completed, assessing hearing loss and physical activity interventions. We'll then conclude today's presentation by discussing some future directions of our research, which include assessing the barriers and facilitators to physical activity in adults with hearing loss, and finally, where we intend to develop and evaluate a digital intervention in this area. So in terms of existing evidence assessing associations between hearing loss and other health comorbidities, you'll probably all be very familiar with research showing that hearing loss is associated with an increased risk of developing non-communicable disease, particularly in older adults. Now, these diseases include dementia, diabetes, and cardiovascular disease. Older adults are at an increased risk of developing non-communicable disease if they live a physically inactive or sedentary lifestyle. And what's problematic is that adults with hearing loss are often shown to be inactive. Now, what we're interested in is to assess the associations between all of these factors, namely, how is it that hearing loss, non-communicable disease, and physical activity are all related? And what we're showing you here on the right is a potential diagram of how we might like to account for some of these factors. So at the top, we've got cardiovascular risk factors, including central obesity, diabetes, physical inactivity, and hypertension. And then these are all associated with a heightened risk of cardiovascular disease. So how is it that these might mediate or moderate the associations, say, between hearing loss and other non-communicable diseases, such as dementia?
So to investigate these associations, we carried out an online survey that ran from February to July of 2020 to look at the links between hearing difficulties, psychosocial factors like loneliness and depression, and non-communicable disease risks such as physical inactivity, diabetes, and hypertension. The total sample had 389 adults with an average age of 41, and most of the respondents identified as female and white British. Over half had at least a bachelor's degree, and over half had self-reported hearing difficulties, which was measured by their score on the revised hearing handicap inventory. Around a third reported memory problems, and only about 20% were involved in sport. As you can see from the diagram, hearing difficulties were associated with a number of health problems and behaviours, but just to highlight, people who reported hearing difficulties were less likely to play sport, were more likely to report memory problems, and experience poorer psychosocial well-being and cardiovascular health. Interestingly, we found that age moderated some of these factors, and therefore we divided the sample into two age groups: younger adults who were aged 18 to 39 years and older adults who were aged 40 and older. Further analysis using logistic regression demonstrated the association between hearing and memory problems were present in both the younger group and the older group, suggesting that hearing interventions may be beneficial at any age. We did, however, find some age-specific differences, where only for older adults was sport participation associated with hearing difficulties and memory problems. So, older adults with hearing difficulties were less likely to be engaged in sport, and those with memory problems were also less likely to be engaged in sport. This suggests that promoting physical activity in older adults with hearing difficulties may be especially important to help reduce the risks of non-communicable diseases such as cardiovascular disease and dementia. However, these associations were only based on self-reported data, so we carried out a follow-up study with a sample of the total survey. So for the follow-up, which is still ongoing, we conducted an experimental study over video call, where we first asked participants to take the Hear Who app test, which is a digit and noise test as a measure of hearing loss, followed by the modified version of the telephone interview for cognitive status, which was presented auditorily, the Hopkins verbal learning test, which was presented visually, using a timed PowerPoint, and the verbal fluency test. So preliminary results on the first 36 participants found that those with hearing loss, based on their Hear Who scores, had significantly lower scores on the TIX-M compared to those with normal hearing. However, there were no significant differences between hearing and scores on the HVLT or the verbal fluency assessments. We also found that scores on the Hear Who app were strongly correlated with the self-report measure of hearing difficulties, though we found scores on the cognitive measures were not associated with self-reported memory problems. And though these findings are only preliminary and on a small sample, they do provide support for using alternative presentations of cognitive assessments for older adults with hearing difficulties.
Now, in addition to the self-report and behavioural studies that Maria has outlined, we've also completed a systematic review to assess interventions that aim to improve physical activity in adults with hearing loss. Now, in terms of our inclusion criteria, when we look at our PICOs, so our participants, intervention, comparators, outcomes and study designs, we only included studies that incorporated adults greater than 18 years of age and had established mild to moderate hearing losses. We were interested in studies that assessed any behavioural change intervention that increased the level or amount of physical activity when compared to either a passive, no intervention group or an active, so an alternative intervention group. We were interested in outcomes including functional fitness, cognition, physiological and psychosocial measures, as well as hearing and general health related quality of life. We included study designs that were either retrospective or prospective, as well as randomised and non-randomised control trials. Now, on our initial searches, which were completed in May of last year, we identified 3,705 records for us to confirm eligibility. Now, based on our PICO's criteria, we narrowed this down to only 2 studies. One completed by Jones et al. In 2019, and another by Bruce et al. In the same year. Now, in both of these studies, interventions include a form of exercise. In Jones' study, this was group exercise as well as group auditory rehabilitation, whereas in the Bruce study, physical activity was interleaved with cognitive training. Now, when looking at the primary outcome, both studies included one measure of functional fitness, which was chair, sit to stand, as well as the 1-foot balance test. Now, in terms of chair, sit to stand, we were able to pull data across both of these studies, which showed that there was a significant improvement for those that completed the physical activity intervention compared to controls, which in both studies was an inactive control group. However, in comparison, the 1-foot balance test data pulled across these studies showed no significant effect. Therefore, based on these findings, this could suggest that that functional fitness, it's very much dependent on how it's measured within the studies, whether or not it shows a significant difference or not. Now, we were unable to show pooled data for secondary outcomes because either one study only assessed these outcomes. Now, what we show here is that there were no significant differences between groups for cognition, as measured by Bruce et al., as well as psychosocial well-being, hearing-specific health-related quality of life and general health-related quality of life as measured by Jones and colleagues. Overall, what we concluded here is that unfortunately the available evidence to date is of low quality and subject to bias due to study design limitations. And we suggest that further high quality research is needed in this area to determine whether interventions that aim to improve physical activity in older adults should be incorporated into oral rehabilitation.
So, following the findings from the systematic review and the associations we found in the observational studies, we've begun to qualitatively investigate the perceived barriers and facilitators to physical activity in a sample of older adults. And so we've been doing this using semi-structured interviews where the responses will be coded according to the theoretical domains framework and mapped onto the combi model within the behaviour change wheel, as you can see from the diagram. So this is a supra theory from health psychology, and it provides a framework and systematic guidance for developing theoretically driven behaviour change interventions.
So to that end, we plan to build on this qualitative research in order to develop and evaluate a digital intervention that aims to improve physical activity in adults, specifically older adults with hearing loss. Now, in order to design this intervention and develop it, we want to use a user-centered and participatory design approach, which will then ultimately lead to a high-quality study assessing the intervention's effectiveness.
So thank you all for your attention. If you have any questions or comments or feedback, please contact me at the email below. Thank you very much.
Thank you.